All right, welcome back, everybody, to the second in a series of conversations with Dr. Kris Wusterhausen. He's our peptide man, and if you listen to our first episode, we were starting to learn about peptides and the impacts that considering a peptide um, application for your patients in your practice. And so today, what I was wanting to do was kind of talk about maybe the top two peptides. Give us a little background first on, when you talk about, and by the way, welcome, Kris.
Thank you. Thank you for having me.
Yeah. I was thinking about our last conversation, and when you talk about peptides, especially in, you think about the vaccines that they're talking about for COVID or these therapies and all. And we usually think of medications, or we usually think of vaccines, but I'm curious about would why would a physician maybe consider peptides as a potential application for someone in this COVID situation?
That's a great question, and there's a multitude of reasons, but I'm going to try to keep it fairly simple. One thing, I'm going to talk about peptides in general because I know we're going to get a little bit more specific here in a few minutes. But, first of all, peptides are considered in the medication category, but they're a more natural type substance for the most part. As we said in the first podcast, there's over 7,000 naturally occurring peptides in our body. Peptides are simply chained amino acids in a sequence to create a function. And so we're able to use these peptides in ways to basically modulate our own immune system to work more, I'm not going to say harder, I'm going to say more efficiently. And so that ultimately we are able to, have our body basically heal itself. And I think that's why peptides are really important. Their safety is so good. They're extremely safe overall. I would make the case a lot more safe than some of the protocols that you see out there right now. And TA1 in particular, that we'll talk about here in a minute, actually augments vaccines. It actually helps your immune system work better along with that vaccine to actually have the immunity that you need. So I just think that they're a really great addition for COVID, not only COVID prophylaxis, but also COVID treatment.
I've listened to some physicians talk about this COVID situation, and they broke it down simply where even I could understand. But it's interesting to me that the thing that destroys the virus within the cell is like vitamin D or zinc. But the problem is, at least from my understanding, is that to get into the cell, it needs a little bit of help. But the point I'm wanting to kind of reflect is that I was shocked. My default expectation is a medicine will solve the problem, but what I was understanding was your body could totally handle it if these things, if the zinc or the vitamin D could get in the cell, then it would take care of itself.
Well, and so if you think about it, what really is perplexing about this disease is why does one person do so well and another does not? And I think that we, of course, are still trying to figure that out completely. We don't have the complete answer to that currently. But the one thing I think that is important is we have this perception that that so many people are perfectly healthy that get ill with this disease, and I think that's a little bit difficult to say a lot of the time. Just because you don't take a prescription medicine doesn't necessarily mean you're perfectly healthy. I'm 48 years old. I don't technically take, normal prescription pharmaceutical drugs, but I know that at 48 years old, I have a little mild heart disease that I'm trying to deal with and some other things. And I think that unfortunately, a lot of Americans aren't as healthy as they think they are. So I think that's one really important factor. But the one thing we know for sure is that vitamin D deficiency absolutely does play a role in how your body handles COVID. And, most Americans are vitamin D deficient. It's one of the things that even when COVID's not around, that I tell my patients a lot of times, if you get nothing more out of this visit, please just understand to take your vitamin D. So normally I have my patients taking 5,000 international units of vitamin D a day. I've been recommending to most of my patients right now 10,000 units of vitamin D a day for about 60 days. And then they can bump back down to 5,000 just to really get that vitamin D level up there. And a lot of times it's kind of like a battery. Once we can get it charged, it'll stay really good for quite a bit of time. So yeah, you're very right. Like my supplement protocol is vitamin D, zinc, and vitamin C, vitamin D, and zinc for my patients who are trying to optimize their supplements for prevention of COVID. And then if they get COVID, we bump those levels up a little bit more. And most people will do, believe it or not, extremely well with COVID just with that.
Mm-hmm.
If they don't have a history of lung disorders, asthma. But it's tough because I don't remember if I said on the last podcast, but I just worked this weekend with a 40-year-old doc who ran 7 miles a day, that had asthma, who ended up in the ICU and was just about to be intubated with COVID, simply because of his asthma and how much worse it got. So, you just never know with these different patients on what's going to happen. Luckily, he did some of the things that we'll probably talk about here in a minute. And 2 days later, he got discharged from the hospital and did very, very well.
Wow. I think you think about a physician is in a little bit of a dilemma in that if you have something that would work as a prophylactic, if you would want to promote it, or you would want to encourage people to start to take it or apply it, whatever the situation is. And we think about these peptides. How would a physician approach that to let their patients know that potentially there's an application they could consider that might help prevent it or make it what's the course run shorter or easier if you were to contract it? What would you do?
Yeah, that's always a tough one because, unfortunately, even though TA1 does have some FDA indications, we're not using it. We're kind of using it off label here in this scenario. So you just have to be a little bit careful on, I can't go out there and put a billboard out on the interstate right beside my office saying, come here for COVID treatment.
Yeah.
What I did in my practice is I think I did a well-crafted email to my patients that I felt would benefit from it, explaining actually not just TA1, but what we just talked about, vitamin C, vitamin D, zinc. I encouraged increased water intake, improved exercise, improved diet. The supplements, of course, and then for those patients that maybe felt more at risk, maybe they just have a public job, I recommended the Thymosin alpha-1 prophylactically. And it's amazing so far that all those patients that have been on Thymosin alpha-1, I've yet to have anyone actually get COVID. Now, I can't say that is a prevention completely, but, so far, and actually, I was just this weekend at my mastermind training with Peptides under Dr. Seeds, and the same thing by all other physicians was the same exact thing. No one has actually given TA1 to any of their patients that actually came down with COVID. Multiple ones of us have had patients that have taken TA1 in households that got COVID, but not the actual patient that was on TA1 got COVID. So, but more than anything, it's just talking to your patient. So the thing I tell the providers is, and I did a lecture last night on this exact topic, is you've got to get comfortable with the peptide first. You, the provider, you've got to use it. You've got to treat maybe people close to you that you feel comfortable having this conversation and treating. And then once you're comfortable, you just start rolling this into talking to your patients, especially those patients that you feel are more high risk if they were to get ill. Even forget about COVID. I know right now it's on the top of my mind, but it will eventually fade. I know it doesn't seem like it will, but it will. But then a normal season, then we'd be approaching flu season right now. So that'd be another reason to bring it up with those patients that are possibly susceptible to the flu. But there's a lot more than just preventing illness that this peptide can do.
So this particular one we want to talk about first, I guess, would be the TA1, as you're calling it. What's the name that doctors can say, but I can't?
So it's actually naturally produced in the body by the thymus gland. So we call it thymosin alpha 1. So
Okay.
TA1 for short, but it's actually just thymosin alpha 1. It is naturally produced in our body, so it's a bioidentical peptide, and it has been FDA approved for hepatitis. It's been used for many many years. One of my favorite applications in it is actually in cancer patients. It does a great job of augmenting any type of cancer treatments a patient may be getting, or
Wow.
even a patient that maybe decides, for whatever reason, they're not going to do traditional chemotherapies or biologic agents or something of that nature. Thymosin alpha 1 would be a great uh, addition to their regimen. So the only thing I tell providers on that one is I certainly know it won't hurt the patient. But if you do have an oncologist on board, you probably need to consult with that oncologist so that you don't
Hmm.
ruffle feathers. Unfortunately, you can sometimes get an oncologist that maybe is not familiar with peptides, and they can get a little ruffled. So when there's a specialist, I like to usually have the patient tell them what I'm up to, give them my number if they want to discuss it. Most of my docs around here are pretty comfortable with what I do, and we don't seem to have too many issues. But no, TA1 can be used for a multitude of things. I'm a big believer of, let's move away from COVID for a second, as hard as
Yeah.
it is to do. Guys like you and me, and we discussed this a little bit in the last podcast, but as we're going through a process, most likely some of us more than others, of cell senescence. And, I'm just a big believer that if you fix the cellular function, like you had said, if you can get the things into the cell, or,
Hmm.
I always kind of take it back to the engine of a car. You can have the most beautiful car in town, but if your engine has got a blown head, it's not very useful. So we want to make sure that our cells are communicating with each other. They're repairing themselves, which is called autophagy. If they don't think they can repair themselves, that they're killing themselves, that's called apoptosis. And we're wanting to prevent this process as we age that happens more and more, called senescence. And again, senescence is simply a zombie-like cell that doesn't die and is not performing its functions properly and is kind of hanging out there. And TA1, along with possibly a growth hormone secretagogue, such as the one that we'll discuss in a minute, work very well at trying to assist the body to basically either pull that cell out of cell senescence or simply rid the body of those cells. Because a lot of us believe in age management that those are the cells that turn into cancer down the road, turn into, set up the body for diabetes and a lot of other chronic inflammatory type conditions.
I'm reading here that it says here the drug's in phase 3 trials for the treatment of hepatitis C, and in phase 2 trials for hepatitis B. It's maybe there's some here things of indications, possible indications of helping with malignant melanoma. Yeah, that these
So
are
really,
some.
it can really help with all carcinomas, and it's been actually used with hepatitis for many years. The peptide's been around for quite a while. Like I said, we make it in our body. Okay,
Yeah.
we already have this in our body. We're simply augmenting it. And what's crazy is there's some, like we use it in typically somewhere in the 450 to 1500 microgram doses. There's studies where it's been used up into I would think it's 20 grams at a time with no side effects. And so I've never had anyone have any adverse events with it, no side effects of any consequence. You really can't overdose anyone with it. I don't typically treat kids in my practice, but there's even studies with using it in children, pediatrics. So it's just an overall really safe product that's part of our general protocols of how we treat aging in our office. It's just really come to the forefront because of COVID. And I don't know if we've discussed, I don't think we have today, a recent study out of China with thymosin alpha 1, TA1, in severely ill ICU hospitalized COVID patients. By simply adding TA1, mortality dropped over 30%.
Wow.
And so I think that's pretty amazing.
So is it like, if we have the zombie cells, would it make sense that we have these zombie peptides, that adding these peptides in like reawakens them or boosts them? Help me see what's going on.
So not really zombie peptides, but so I think, again, most guys understand that as they age, I always like to use testosterone because, yes, I do a lot of testosterone in my practice, but guys generally can relate to testosterone.
Mm-hmm.
For most guys, they get mid-30s to early 40s, testosterone starts to do simply a downward curve.
Yeah.
Well, guess what peptides do as well? Exact same curve, okay?
Okay.
We were meant to be born, reproduce, and die.
Mm-hmm.
And as one of the docs I've trained under, he's always like, that's why we're depleted. In addition to environmental issues, stress, our food, but our hormones and our peptides really start to wane for most men and women in their mid-30s to early 40s. So I don't really think the peptides go zombie on us, go rogue. They simply just aren't in enough of an amount to do what they're supposed to.
So kind of like low P as like low T.
Exactly. We may start something new, low P syndrome.
So what's the other peptide? Now you said there were two that you'd like to discuss. Do they, and when you're going to tell me here in a minute, but do they work together? Is that why you like these two, or you like to start off?
Yeah.
Yeah.
Yeah. So I was actually, again, when I was talking to the couple hundred docs last night, I was telling them, and I do say this, that most providers and most patients would do very well if they only added, if most providers just got comfortable with anywhere from 3 or 4 peptides. Mm-hmm. They can make such a difference in their practice. I think right now they're on the market there's over 60. In my practice, I probably use 10 to 15. I actively use, like on a daily basis, probably more like 3 to 5. And there's special circumstances where we'll use these other ones. It's kind of like they used to say when I did traditional family practice docs find like 50 medicines that they use like all the time. Yeah. And then they dig from others, oh, okay, yeah, I've got this condition, but they have their 50, 60 meds they get real comfortable when they use. And so I say that with peptides, but if you had to, make me choose only one peptide, that one peptide would be CJC 1295/ipamorelin. It is my favorite peptide. I love TA1. She's a very close second. She's become so popular right now simply because of the COVID situation. But how CJC ipamorelin works, and I think it's important to differentiate this because a lot of my patients even come in and they're like, hey, I want to talk to you about what you prescribed for my friend. And I'm like, what did I prescribe for your friend? And they say growth hormone. And I'm like, I did not prescribe growth hormone for your friend. And I think that's just important that we discuss the differences. Growth hormone is actually extremely difficult to legally write by a physician in the United States. Mm-hmm. There are some very, very specific guidelines. You really can only use it in true growth hormone deficiency conditions. And that is very, very rare in adults. 2, the cost of growth hormone is astronomically high. It's $700 plus cost per month for growth hormone, and your insurance isn't going to cover it. 3, long-term use will shut down intrinsic production, so that if you use it for too long and then you stop, now I really need it because now my body doesn't make growth hormone anymore. And there's also some mild risks of cancer that we believe is associated sometimes with growth hormone, although I don't believe that's been proven, and I don't know that I really buy into that, but you will see that written out there. Plus some swelling and some carpal tunnel syndromes more likely. But really and truly, I think it comes down to the inability to truly legally write it in America for doctors is very difficult. And two, the cost is just very off-putting. But the biggest thing that I see with growth hormone is it really causes a high incidence of insulin resistance. And so in other words, if you use growth hormone for a long time and you don't monitor it close enough, you actually can cause diabetes. And there was a great study that was done just a few years ago called the TRIM study, where they put 10 or 12 patients on growth hormone, DHEA, and metformin, and they were for 6 months, and they turned their biologic clock back 2 years and 6 months. So that just shows how well growth hormone works. The problem with that study is I think they'd have been much better off if they didn't use CJC / ipamorelin, because that does not have the insulin resistance associated with it. The problem with growth hormone is that when you're using it, you're basically causing supraphysiologic doses of growth hormone. You're giving a person growth hormone. So think of it just like a testosterone shot. You know, if I give myself a lot of testosterone, but my testosterone's already pretty good, then obviously my testosterone is going to be pretty dang high whenever I put testosterone on top of my own testosterone. How a growth hormone secretagogue works, or CJC ipamorelin, is it's causing just simply your body to make more and release more, especially at night while you sleep. And so you don't get necessarily super physiologic doses, and it follows the normal circadian rhythm of your body. So you don't get the side effects that we expect when we associate with growth hormone. We're not limiting any endogenous production of growth hormone. If anything, we're amping it up. So you could use this for a few months and stop, and you don't have to worry about your growth hormone production. Basically, we're getting all the good without the bad. And that's the great thing about it. The effects of growth hormone are, you know, I simply tell guys, they'll say, well, that are on testosterone replacement, they'll be like, well, what's it like? And it's like how you felt when you got on testosterone. It's like feeling like that, but just maybe like 20%. So it's not earth-shattering when you use it. This is typically for guys who are already on testosterone or girls who are on hormone replacement. We're just simply helping the body 20% more, if you want to say that. We're helping the body gain more muscle mass, lose more fat, modulate the immune system, help with cell senescence. We sleep better. We're mentally more clear. And we just overall, when that's all done, we just feel so much better. Then when you add the TA1 on top, they work very synergistically together on that cell senescence. So like when my patients come in and they're on hormone replacement and they say, hey doc, I just want to go a little bit further and see what all I can add. This is, you know, if they're willing to do peptides, this is the protocol that I try to get them to use most of the time, is a CJC ipamorelin along with a thymosin alpha-1. The good thing about thymosin alpha-1 is it's twice a week subcutaneous injection. So, you know, you can pick 2 days a week and use that. And then the CJC ipamorelin is 5 nights a week. So, you know, it sounds intense, but the patients get the results after a couple of weeks. They're usually fairly bought into doing it.
So the physician would prescribe it. They would go to, is there a compounding pharmacy that you would go to, or how do you, talk to us about
So I mean,
that.
there's a few different pharmacies across America that make these products. It's certainly not something that we send down to CVS or Target. You know, you have to deal with, and it depends on your state. Some pharmacies, so for a pharmacy to ship a medication to you in your state has to have a license in that state. So some of these pharmacies don't necessarily have 50 different state licenses. So you know, I usually start with my physicians and just kind of start, where do you live? And then try to kind of work backwards from there on which pharmacies they can use. But like I said, there's not, I don't know the exact number, but I would say there's probably easily under 15 pharmacies that truly do this routinely, making peptides.
Wow. And again, this is not something that's real unique and new. Actually, peptides are being used by a lot of physicians. Remind me again how many physicians are currently
Oh, I'd probably
utilizing
say
them?
at least 20,000 plus if I had to guess. I don't know an exact number, but I can tell you this much. When I go to the big conferences on peptides, there sure are a lot of people there.
Yeah.
A4M is one of the biggest sponsors of educational peptide courses, and you'll have a ballroom packed full of providers. It's becoming more and more common, and I really think peptides have really gained steam over the last 4 or 5 years, and I expect the next 4 or 5 years, when it comes and goes, I think you'll start thinking of peptides just like you do testosterone. I
Hmm.
always think, 10 years ago, you would have never heard a testosterone ad on the radio. I don't
Right.
think you can go 10 minutes now without hearing one, at least not in Dallas, Fort Worth.
Yeah.
So I really think that's what we're going to end up with peptides in the next 3 to 5 years. But it's important too I think we talked about it last time, but I like to reiterate, I think it's important for docs and patients to understand we're already using peptides right now in traditional medicine.
Hmm.
And there are many things out there to treat cancer and diabetes and other conditions that are absolutely peptides. Okay, so this isn't a new concept. These are just products that physicians sometimes haven't had access to. They just haven't trained on, and so they just have to kind of get used to it, read about it, read back up on the science, and I think their comfort level will go up very quickly.
So to me, as a patient, to realize that there's a potential for me to sleep better, maybe lose a little weight. I've been working out, but I just can't, I keep joking. I got the COVID-15, and it's like the 15 pounds
Yeah,
I gained since COVID
I hear you.
started. And, I exercise, but I had to change the way I exercise from when I was young, or I was going to hurt myself or injure myself. But there's just this, I've aged. And to think that there's actually a therapy, or however we want to call it, to support me, or to kind of recharge my battery somewhat, is somewhat exciting.
The results that patients get, when I first started using CJC ipamorelin, I simply only used it in my fitness patients who wanted to either weren't getting the results that they wanted or wanted to take their workouts up another notch safely. Is those were the patients that I started on, and I have yet to run into a patient who uses the products correctly, who's a good candidate to start with,
Hmm.
who uses the products correctly and routinely, who actually follows good nutrition and a good diet, that's not blown away by how much it helps them with that. And also less injuries, less soreness after workouts. I mean, those are important things to realize as well.
So where is, as a physician, would I like, is there a course that I would go to, or is there a certain, yeah, talk to us about how to kind of get educated, maybe get in a group, or learn more about how I would begin to successfully implement this in my practice.
So it's getting easier now. When I started 5 years ago, it was pretty much self-study. I when I started, I got exposed to peptides by TaylorMade Pharmacy. They happened to have some great studies and educational materials that they were able to provide me. I felt comfortable enough to prescribe it to a few of my patients, 3 or 4 patients, saw the results, got more comfortable, started to prescribe more. And then over the last 2.5 years, there's the education has really started to pick up in peptides. They actually now have peptide certification courses. A4M is one of the big entities in age management. It's the huge age management medicine group that is for education. So they do peptide certification. There's a smaller group that I'm a member of, AMMG, that does some. I also teach for BioT, the maker of bioidentical pellets. I am helping them right now launch their peptide program. So if any physician out there is listening and is already using BioT, they have access there. You don't have to actually use BioT pellets, from my understanding, to be part of their peptide training. And of course, I train under, or do train under, I still do. I still tell every physician, peptides are ever changing and more rapid than anything in medicine right now. And I'm going to every 3-month training, actually on-site training every 3 months. I just got back this weekend. The next one's already scheduled for October. COVID hopefully lets us do that. And that's Dr. William Seeds. And he actually does have a peptide textbook that is supposed to be hitting the shelves here in the next 2 to 4 weeks. So, maybe if a provider has some sort of interest, but they're not quite sure how far they want to dive in, I think that would be a great way to go, just to follow Dr. Seeds on any of his social media platform, just like it sounds, SEEDS. And when his textbook drops, I think that would be a great thing, to purchase. I'm sure it won't be too expensive, and read it. I've actually got it now, but it's, not hit the market yet but at our training we got it. And I think I read a third of it the other day, just on an 1.5-hour flight home. So it won't take too long to knock it out. And that'd be a great place to start as well.
So you mentioned pellets. And so far, I've envisioned oral application and injections, or subcutaneous injections. Pellets, what does that mean?
So that's for hormone replacement. So currently, many pharmacies are making pellets, testosterone and estradiol estrogen pellets that you can place under the skin. And so, still the biggest part of my practice is hormone replacement. The peptides kind of come on top of that. And, we've been a hormone pelleter at our practice now for nearly 10 years. I do use gels, creams, injections as well, but I am a huge fan of pellets for the majority of my patients. And so BioT is the company that I use that manufactures those pellets. Okay. There's multitudes of people. I just think BioT is the best, the market leader, and so that's who I've chosen to use in my practice.
All right. So there's not a peptide application that would be a pellet form right now?
No, peptides primarily are injectable, but they do make oral peptides. There are a few, BPC 157 being the main one. There are, of course, topical peptides like that you can use for lines and wrinkles and repurposing this, just making the skin look nicer. There are transdermal peptides, but as far as I know, I haven't heard of any pellets that are peptide pellets. But who knows? Maybe we'll come up with one.
So I guess in a therapy situation, I'm wondering about how would a physician start to design their fee schedule, or how would you approach that with the peptide treatment?
So yeah, that's actually the majority of the discussion that we had last night. There is no set standard on this, Steve. It's up to each clinic to decide how they want to do it, and we are not allowed to mark up pharmaceuticals in America. So in other words, I can't go buy Synthroid for $10 and sell it to you for $20.
Right.
But we can do programs, okay? And so we are allowed to charge for our management, I guess is what you would say. And I usually tell my providers that, we add a clinical management fee on that. And I how you do that is up to each provider. In other words, how much you charge is up to every provider. The one thing that doctors typically do, and actually we had a business manager talk to our mastermind group this weekend, and it's something that kind of hit home. And he was saying, every man and woman in here, there was about 30 providers, and that's usually about how many of us are. And he goes, y'all are the class leaders in this country for peptides. And you have to realize that there is a certain fee that that has to be associated with that knowledge. And as providers, we typically don't charge probably as much as we should, to be perfectly honest. If it's
Hmm.
left up to the doctor, the PA, the NP, we tend to kind of go on the side of just giving things away. And then unfortunately, that would be great in a world if you could do that, but that's also how you don't keep your practice open. And so that's where I've worked with a lot of different docs on just kind of how to charge for these things. We're moving to a subscription model, though. That's
Hmm.
something that I think we'll be rolling out in the next month. We went subscription with our hormones at the first of the year, and it's been a big success for our practice. And so I think we're going to move to a peptide subscription. And because really and truly, like if you came into my office and we're talking, I really want you to be on most likely 2 peptides, not 1.
Yeah.
And we really want to not even really discuss how much does 1 cost versus 2.
Right.
We want to just make it affordable to where a person's like, Steve, this is what I want you to be on. And then you look at the price and go, okay, I think I can do that. And I understand why you want me to do it. Because it's like anything, if you kind of do half of something, you may not even get half the results.
Right.
And so that's just the important thing is you want patients to have good experience. You want them to get healthier. I don't lie to providers. Peptides aren't cheap. These unfortunately are not $25, products.
Hmm.
So unfortunately, some of my patients can and can't afford it. But I think if you kind of do it as a monthly fee, though, that starts to get to where at least someone can budget out that amount of money. And now with these new DNA testings that we can do with biologic aging and very accurately, very, very accurately tell a person their biologic age. And now based off like what we saw with the trim data, that we can actually use this for 6 to 12 months and say, oh my God, I was biologically 50 years old a year ago and now I'm 46. I think that's amazing that now we can do that kind of data with patients to truly give them an objective data that is not from my office.
Right.
The company that we're going to start using most likely starting next week's in Europe. So, I mean, I just think that's a nice thing to show patients, to help really cement what we're doing.
That's what I was wondering is, so would you just do that test, or would you like do a deep set of labs as well to help you design yeah, the therapy protocol that you would do? I don't know the right name.
So the answer to that is yes and no. It's a great question. It got asked last night, nearly word for word, from an actual doctor. Okay, and peptides themselves generally are working on things that there are no lab tests that are going to tell you that there is an issue with like this peptide. Okay,
Right.
if they do exist, the labs cost so much that they're cost prohibitive because you're getting in such to a specialized test that you're talking like $1,000 for one simple test. So if patients come to me and they say, or providers, excuse me,
Hmm.
providers come in and say, what kind of labs do I have to do a lab to use a peptide? And I say, really very, very basic: kidney, liver, white blood cells, red blood cells, platelets, maybe check the thyroid. That's all you have to do. Do I recommend more? I do. I like to look at inflammatory markers. I like to just get an overall feel for what I believe their biologic age is without looking actually at the biologic age. Because
Hmm.
there's a lot of things I can look in blood and biomarkers to basically kind of give you an idea of how you're aging. The biologic age test is simply doing nothing more than giving us one more tool in the toolbox that isn't horrifically expensive, under $500, that you can try to talk someone into doing once a year to show them what their biologic age is. But I wouldn't just use biologic age as, how I'd want to look at a patient. It's just one more tool to really look at someone, especially as they're starting to get my age, approaching 50 and above. I think it's really, really important to start looking at those things.
But it seems like it would stand to reason that if you were to take a set of deeper labs that showed you these different markers and inflammation, and then after 6 months of peptide therapy, if you're feeling better, if you're sleeping better, would it not show that some of those markers would have improved or gotten better or moved from the red to the yellow or the yellow to the green?
Yeah. Well, first of all, I tell every patient my first goal is to get you feeling better. And I'm nearly happy just with that. You know, if a
Hmm.
patient comes back in and says, I'm sleeping better, I've got more energy, I'm working out better, my sex life is better, you know what? Really, at that point, we've darn near already won. Okay. So
Exactly.
everything after that is just icing on the cake. So, you know, you do. I always hesitate when I see a patient on the first visit. I say, in 6 months, I hope I will see improvement in these
Yeah.
markers in 6 months. I always try to prep them for 1 year. I just think that some of these things move so slowly in time that
Hmm.
you'll feel better, you'll do better, but these markers sometimes take a full year before you really start seeing the difference. Like some patients, like, okay, do we recheck this blood panel in a month? No, because I
No.
don't want you to be discouraged. I don't want you to look at it and go, well, crap, that actually got a little worse, because you know everything
Right.
goes up and down, and you
Right.
can discourage a person. That's why for me, I probably am not, the DNA testing is something we've been doing now just for a few months. I probably won't do it every 6 months because I'd be afraid Steve's didn't get better in 6 months. Then Steve gets frustrated and quits versus if I did it in 12 months, I feel pretty dang sure that that's going to have made a big difference in a year. That's just kind of how I look at it. If a provider says they want to do it the other way, I'm certainly not going to fault them. I just, you know, I really want, if, if, if I want to get the results that I want, I really want patients to commit to me for a year.
Yeah.
And I feel like after a year, once they've committed to me, then they're going to see the proof in the pudding at that point, and they're going to want to continue it from there on. I certainly would never say, you know, give me 3 months. You know, that's just not enough time to get some patients turned around.
Well, I think that what's the question I haven't asked that I should have asked during this conversation around this topic?
I think we've really hit the biggest thing. I mean, most of the big topics. I think we probably should just hammer back down on the safety.
Hmm.
You know, I think that if I'm a patient, cost and safety are probably the two things, and I don't know. Hopefully, safety then cost in that order. And you know, I mean this wholeheartedly. I prescribe antibiotics, you know, that make me more concerned about a patient's well-being than I do peptides.
Wow.
You know, the only thing you have to be careful with, as we kind of talked about it before, is unfortunately most physicians in America are not familiar with peptides. And so you just got to pick your patients wisely, because if the patient is destined to do poorly and they do poorly on a peptide and another doctor doesn't understand peptide, guess whose finger is going to be pointed at?
Right.
They're going to point it at the doc who prescribed a thing that they don't know anything about. I find that with testosterone these days. I'm always amazed at what doctors will tell patients about testosterone. I'm like, that's not even remotely true. We thought that 15 years ago. We proved it 10 years ago that wasn't true. But you know, there's this common misperception that doctors know everything about medicine. And as I always joke, I'm more than willing to say what I don't know. I said last night, hey, I admit I'm not the smartest doctor that ever lived, but I think I have common sense. I think I can go back to basic science and really look at these things. And I'm never afraid to tell my patients, hey, that's out of my wheelhouse. Or, hey, my patients always have taken it well. You know what? Let me look that up and I'll get back with you. You know, I saw someone the other day that posted like a meme that said, why do they still call it family practice? If my doctor doesn't know what he's doing, I don't want to go to him. I'm like, that's a ridiculous concept. If your doctor knows it all, then you've got the best doctor ever. But we're all learning every day. And this isn't, everything changes on a daily basis. Heck, COVID's a great example. You know, it seems like something new every day with COVID. So we're always got to be learning and pushing. But long answer to a short question. I just think pushing the safety and for patients and providers understanding how safe these products are is very important.
Just impresses me that this would be a therapy that maybe a physician would be excited about because it really it really seems to speak to the reason you got into medicine in the first place. If you could prescribe something you feel better about, I never really considered that. If you prescribed a medication, knowing the side effects, there would be this concern or a little bit of stress, knowing that this person's going to experience something. But we're trying to make an improvement. But
Mhm.
here's this peptides with very low chances of side effects that could actually make that person feel better faster in many situations. Seems like it's a no-brainer to me.
Well, it actually puts providers back to being healers, in my opinion. You know, I got out of traditional family practice years ago because I got to where I just felt like a pill pusher, to be really honest with you. And I'm not knocking any primary care physicians. Thank you. You do a
Mhm.
great job. We need more of you. I'm not knocking them. It wasn't for me. And I realized it was killing me, literally. The stress of that, you know, was just so tremendous. Peptides, my practice became reinvigorated when I introduced hormones to my practice.
Yeah.
I was hormone deficient, brought it in my practice. It reinvigorated myself and my practice, and my patients come in and they're happy to see me. And it's just, I very rarely have patients come in and see me here at the office that are upset or, you know, angry. That was an every 30-minute occurrence at my other practice, because, you know, people didn't feel good. When you don't feel good, they're grumpy. And
Hmm.
especially some of the older patients, they come in, they love you, but they're also ready to bite your head off at the same time. And then I got kind of a little bit flat with hormones, because, you know, once you kind of know hormones, you kind of know hormones, in my opinion. Did it for quite a few years. Peptides has actually reinvigorated my practice again, because, and they're changing so rapidly. I don't think we're ever going to get to a complacent stage with peptides. I really just believe they're going to be changing every few months and years, and new ones and better ones. And it's just an amazing time to be practicing with peptides.
All right. Well, that's Dr. Kris Wusterhausen, the resurgeclinic.com, Kris with a K. And this was the second of a series of conversations I'm going to title The Low P Conversations. And stay
I
tuned.
like it.
We'll be having more of these. And any physicians that are listening out there that you just want to have a good conversation with a good guy, Dr. Kris, you can reach out to Dr. Kris. Dr. Kris, again, you're on LinkedIn, correct? Or tell us where
Yes,
you are.
I am.
Okay.
I'm on LinkedIn. And then they're welcome to email me at just Dr. Kris with a K at theresurgeclinic.com.
All right. And he can get you pointed in the right direction. And thanks for an excellent conversation, Dr. Kris.
Thanks, Steve.
All right, that's a wrap.